Assalamu alaikum. Welcome everyone on board. So we will just try to cover some important points about liver anesthesia. So Abdurrahman, first of all, just think that liver, whenever the any liver dysfunction comes into your mind, what do you think? What will be the changes in what will be the symptoms or signs in a patient with some liver disease?
The patient will have jaundice. Patient will present with may present with bleeding, nausea, vomiting,
Just a
uh,
second. Joined us. You
abdominal
said
swelling.
you said joined us. So if I just make it that just very simple, malaise. Okay, malaise is the first symptom, sense of unwellness. So malaise, and then you can add on fatigue. Okay, nausea, vomiting, even it may be diarrhea, it may be constipation. Okay,
Bleeding.
bleeding. So bleeding will be there will be changes in urine or
Uh,
stool color.
also
So, for example, if we just think about jaundice, so what will be the change in the color of urine and stool?
the clay-colored stools and dark-colored urine.
Why like that?
Increased level of bilirubin
Bilirubin where? In the stool?
in yes.
No, my dear.
uh,
Stool is
oh,
having the
oh,
color.
oh, yes, sir. Oh, melina. If we are
No, no,
talking due to
no, no. Just that's why I asked this question. So actually, the concept is that there is obstructive jaundice. So bilirubin is not entering in the intestines. Okay. So when bilirubin is not entering in the intestines, so the clay colored of stool will come. Okay. And more is bilirubin is going towards the urine. So that became dark and that became white. Okay. That's what happened. And if there is bleeding tendency, that is something else. So it may be hematuria, it may be hematomesis. So hematomesis will be going up, or even it can, if there is a bleeding varices, so it may result in hematomesis, or if it is going down, it will become melena. Okay. And there is another thing which is called as hematochezia or hematochezia, whatever you pronunciate. What will be? This is fresh blood. Fresh blood can also come through the
yeah,
PR. Okay. So all possibilities can be there in a patient with liver disease. Okay. Understand?
yes, sir.
Okay. So now we will just dig more into it. So for example, if we just think about acute liver failure, we are only concentrating on the symptoms which the patient can have. So in acute changes, yes, in acute liver failure, there may be like uh,
Abdominal pain, nausea,
yes.
vomiting,
So
in
abdominal
can
discomfort, pain, okay, nausea, vomiting, diarrhea, fever. Fever may be there, high grade,
yes, sir.
okay, and then uh, like uh, uh, uh,
Confusion, fevers, coma,
yes,
and
sepsis. Patient can develop sepsis. Am I right?
yes, sir.
And now if you go further, so maybe it is because some things can come together with liver failure. So it may be pancreatitis. Okay. So at the same time, there may be some sign symptoms of pancreatitis. So because it comes together, because it may be the cause of it may be anyone, but hepatitis A, hepatitis E, or this alcoholic iron, what else?
Paracetamol.
Paracetamol.
Uh,
Okay. There say maybe some other infection. We will just go to the text and we will just try to fill in the gaps. So, but like you see, in acute liver failure, the patient suddenly may be developing the common symptoms, hepatic encephalopathy. So hepatic encephalopathy with the this can be there. So or generalized symptoms of sepsis, malaise, nausea, vomiting, ascites can also develop, but like there will be it will take some time. Similarly, coagulopathy can develop. You know what is the coagulation factor which has the shortest half life?
7.
Yes. Okay. And albumin also has a short half life. How much it is? Half life of albumin?
I think uh, 20 days or 20 hours. I don't
Not 20
remember.
days. If it is 20 days, there should be no change in there should not be any symptom. It should take time. I think it should be less than 1 day. Okay, it's 20 day. It's 20 half life of albumin. So I'm wrong. I'm sorry. I have had wrong concept. So it's 20 days. I just googled it. So, anyways, so in acute liver failure, there will be certain sign symptoms which you should be looking at. So it is 20 days. Thanks for correction, Abdurrahman. Uh,
Mm.
so okay, so now some more, if we just go some more history with reference to any patient with liver disease. So if you are taking history, because these are the points which are more related to long case, but you should be knowing. So what else history you should be taking with reference to patient if you are reviewing a patient with liver disease? Anyone else want to speak out? Like sexual history,
Yes.
okay, blood transfusion, dental procedure. What about tattoos? Okay. Some religious treatments, like, for example, hijama. It can also have. What else? Anything else comes into the mind? What else history you will be taking?
Hepatitis B, C.
Yes, that will be a direct question, but hepatitis B, hepatitis C, drug addiction, alcoholism. What else? Anything else?
Sir, past hospital admissions about exacerbation of disease, uh, upper GI bleed history, melena uh, history,
What
and
else?
any history of recent infection, any
Any history of jaundice?
Yes, of course, joined us.
and functional status patients, functional class.
Functional class. Okay. What else?
So this will
Anything?
also involve the cardiac history and terms like tachycardia and orthotexia are typical for
Yeah.
hypertonial.
Actually, we will go into of course, the systemic history will be there. I'm just trying to go because that one you will always ask. I'm just trying to go some atypical questions first, and then, of course, the cardiac history or pulmonary history or these things will be there. I'm just trying to. What about birth history? Is it important?
Syndrome.
Like
Syndrome.
this marital history and this birth history with reference to females. Okay, so that is important in female also. Menorrhagia, like this what is that like history of menstrual bleeding. This is because maybe it may be the one of the symptom of coagulopathy. Yes, of course, it will appear in. Yes, very important. Drug history. Drug history is very important. Okay. Which which drug groups can cause liver dysfunction?
High dose of paracetamol.
Paracetamol. Paracetamol actually is in high dose. So common groups, anti-epileptics,
Anti-epileptic drugs.
Antitubercular.
What else?
Anti-TB.
NSAIDs.
anti-TB medicine.
NSAIDs cannot cause liver dysfunction. Trust me.
It's a certain antibiotic.
Which
Antibiotics.
antibiotics? Which antibiotics?
Aminoglycosides.
Aminoglycosides can cause liver dysfunction. I think it is liver and kidney.
Anti-TB.
Very good. Anti-TB, anti-tuberculosis. Then immunosuppressants.
Sir, anti-arrhythmic myodrone.
Amiodarone. Okay. So you should be just thinking, what damage rocuronium does to the liver? Does it damage? Morphine, does it damage liver? Yes.
Sir, morphine metabolism is slowed, but
Nothing. There is no damage. Okay. Common. Just think about what about any medication which a cardiac patient is taking. Think like this, so you will come to know. Like antiarrhythmic, we said one medication which cardiac patients is taking, and it's one of the factor for liver dysfunction. Statins. Okay. Okay. So anti-tuberculous medication, anticonvulsants, high dose of this paracetamol. Okay. Halothane. Rocuronium and morphine does not do anything to the liver. Liver is doing things to it. Okay. Like metabolism will be slowed. Rocuronium or morphine is not doing anything. So be very clear, because in the exam, if you are saying morphine damage liver, it's a very bad impression. It's similarly, NSAIDs does not damage liver. Okay. NSAIDs can cause platelet dysfunction, which can enhance the clinical problems in liver failure. Like similarly, what about sedatives? So sedatives does not cause any damage to liver, but because in liver patients there may be hepatic encephalopathy, so these patients will be sensitive to sedative effects, and it can precede as it can cause. Similarly, what will be the link of NSAIDs? What else? It can cause, of course, kidney damage, so it can create problem. Then it can cause GI bleed. So GI bleed is terrible for liver patients because it is one of the factor for hepatic encephalopathy. There will be GI bleed. There will be more production of bacteria, and then there will be chances of bacterial translocation, and patient can go in uremic encephalopathy. Sorry, this hepatic encephalopathy. So like you have to bring correlations, and same thing will be coming in the whenever you are thinking about history. Okay. So in history, you should be concentrating on these things which I'm telling you. And I know that we can just cram the words for history, but try to understand so that you will not forget. Okay. So this is the sequence which you can follow for this one, as I am saying to you. Just one thing I was just showing to you. Just a second, please. Just pardon me for a second. I want to show you something. Okay. So some of them we have already discussed. So we will just try to have some more. Okay. Just can you tell me a few funny things? Why there is fetor hepaticus, like alcoholic smell? Because of usually the metabolites which are usually cleared by liver, they will not be cleared. So actually either pee, either poo, or now if both routes are not clearing nicely, so it will come in the breath. So that's dimethyl sulfide, and another metabolite, this trimethylamine. Okay. Or ketones. These are the reason. Methyl mercaptan. This is like atypical points. Okay. So anywhere in the body there may be bruising. There may be dental bleeding even. Of course, usually it's with platelets, but it can cause so any orifices like menorrhagia, hematuria, hematemesis, melena, hematochezia. So coagulopathy related questions will be when you are asking one question, you should be considering about all the questions. Okay. And what about this? Why this the spider nevi occurs? You know,
Sir, AV malformation की वजह से.
AV malformation. Okay.
Sir, basically due to low metabolism of estrogen.
Very good. It causes vasodilatation, and even I wasn't aware about this point because sometimes we just cram these words. So actually, this is related to estrogen levels, high estrogen levels. Okay, so it is causing vasodilatation, and it can causes then Palmer erythema. Palmer erythema, why it occurs? Yes. Yeah, I think it's
Hyperdynamic
also
circulation.
yes, hyperdynamic circulation, and I think also it's related to vasodilatation. Okay. So it's also related to the hormones. So this is another thing, and why this clubbing? Clubbing occurs also in liver disease.
Yes, sir.
So what will be the reason for it?
Something to do with the platelet.
Uh, I don't think so. I don't remember about it. I think clubbing, not exact mechanism because usually it's the proteins or something which is controlling the architecture. It is lost. That result in loss of it, and there is clubbing. So I think it's not clear, but it can occur in COPD. It can occur in CLD also. Anyways, so these are, you see, like if you understand in that way, you will never forget. Okay. Okay. So, there will be some, if you just go further. So why there is itching? Why there is itching in liver failure? Okay.
Accumulation of bile products in the skin.
Very good. So
Sir,
bile
the bile
salts,
salts get deposited in skin and they cause
skin, yes. And there is another xanthomas. Xanthomas also occur because of, I think, this fat depositions. Okay. So normally which are metabolized, they are not done being done. So they are causing this thing. Okay. So fatigue, anorexia, malaise, weight loss. Weight loss can occur, but usually because of distension, abdominal distension, the weight will be more. Okay. And then improper metabolism of fat, carbohydrate will complicate the situation. Lethargy. Okay. Polyuria, polydipsia, why occur? It can.
Complication of renin-angiotensin system.
Renin angiotensin. I think there is, polydipsia, polyuria, but I understand the polydipsia is because of reduced intravascular volume. There is extra vascular deposit, like accumulation. And polyuria, why polyuria? Because I think hormonal changes. Okay. So, okay. So anemia, causes of anemia and liver failure. So one will be the loss. Is there anything related to bone marrow suppression as well in anemia of chronic disease? Okay. What else? Is there anything related to erythropoietin as well?
Yes, sir. Decrease erythropoietin production, increase blood loss, nutritional deficiencies.
Okay.
Uh,
So then there is ascites, hepatomegaly, splenomegaly, and some things will be related to the etiology. Okay. So for example, some symptom like, for example, it is copper deposition, it will be in the skin. Iron, it can cause, if it is a young age, it can even cause this iron deposition anywhere. There may be pathological fracture, there may be arrhythmias, palpitation. So a lot of things will be uh, related to the complication which are occurring. Okay. They have written here orange color. Does orange colored urine occur in jaundice? I doubt. Does it happen? Yes, anyone? Okay.
What is the question? Sorry.
Like orange colored urine can occur in jaundice? This is written here. Can
I
it
think
happen?
in obstructive jaundice, it will be.
In
Yeah.
obstructive jaundice, the color of urine is dark, not orange. I think this is a mistake. It is usually brown colored, dark colored urine, not orange. Which
Okay.
medication cause your orange colored urine? There is a medication which cause urine orange color. Yes,
Anti-TB, rifampicin, rifampicin,
rifampicin.
anti-TB.
Yeah, this we don't forget. This is in our childhood memory. Am I right, Vajiha?
Yes, sir. Okay.
Okay. Similarly, if you forget everything, you will not forget nausea, vomiting, diarrhea. This is in our childhood memory. We never forget this thing. Okay, so behavioral change can occur, melena. Okay, hematemesis, GI bleeding. Okay, so now you can explore as you were saying, Vajiha. So there will be dyspnea, there will be orthopnea, there will be the thing which you were telling. We will also discuss here. Now we will further dig into, like, because you say one thing, we will just try to have a look here. Why this pletempnia orthodeoxia occur? Pletempnia orthodeoxia. Okay, so actually there is
Sir,
vasodilators which are not. Yes.
there is a reason that the nitric oxide basically is compound that is not metabolized by the liver. So there will be an extra nitric oxide in the lungs, so which will hamper the HPV, hypoxic induced pulmonary vasoconstriction, due to which desaturation and that phenomena occurs.
Muhammad Ali, my mind is stuck in the first word which you say. Does nitric oxide metabolize by the liver? No. Nitric oxide is
Okay,
metabolized immediately. Yes, reconfirm it.
okay, sir.
This is not these. Yes, vasodilators which are usually cleared by the liver, they are not cleared. So excessive vasodilators will can cause. This is one reason, but not nitric oxide, because nitric oxide is immediately nitric oxide very short half life. Okay, I don't think so. Reconfirm. Maybe correct. Maybe I am wrong. Okay, so just correct me. So actually, this Vajiha, you were saying this pletapnea orthodeoxia. So there is actually intrapulmonary shunting. Okay, and when the patient is sitting, there is more shunting. So it causes VQ mismatch, and it causes this symptom. So when the patient is sitting or standing, there will be more and when the patient is lying flat, it improves. But the thing is that it's a complicated thing, because of ascites. Sometimes the picture is a little different. Patient has dyspnea all the time. So how clearly it is, yes, bookish. It's more of bookish thing. Practically, I don't think so. You will find this classic feature of litepnia orthodeoxia. I don't think so. Okay, because orthodeoxia maybe you will see, but litepnia I'm not sure, because litepnia is apnea while sitting, and improvement while lying flat. So because I hope you understand that there are some similar, more than one pathologies are going on. So if there is heart failure also, like cardiomyopathy because of cirrhosis, so then actually the picture may be a little worse. So I hope you guys agree. So they do this picture of hepatopulmonary syndrome, okay, which can occur in a patient with severe liver disease, and they with the usually what you will be asking, shortness of breath, or this sleep pattern, and then functional class. What else you will ask? Cough with sputum. What else you will be asking? This question in liver. Yes, clinically you can ask, because this is a academic exam, but I'm not sure, have any one of you, like we have 22 people right now other than me, can any one of you seen this platepnia orthodoxia?
No, sir.
So that's my plea. Anyways, in the exam you have to tell. And when they also do this saline bubble test when agitated saline is injected IV as a contrast medium. So there is, I don't know what happened. The presence of pulmonary vascular shunting is best detected on echo. This incorporates the saline bubble test. You just should name that. Of course, this will be done. And then another thing which occurs with chronic increase in shunting, it develop in pulmonary hypertension. Hypoxia may be severe, which can be reversed by liver transplantation, and occurs in 5 to 8%, and characterized by intrapulmonary vasoconstriction. The finding of a mean pulmonary artery pressure more than 25 in a patient with cirrhosis and absence of other cause of pulmonary hypertension is portopulmonary hypertension. Pathophysiology is currently unclear, and definitive treatment is with liver transplantation. So these are the words they can ask you. Usually, again, this is not in every patient. Okay, and a patient will found to have a pulmonary hypertension. So it's pulmonary hypertension in a patient with cirrhosis and portal hypertension. Okay, so this is another point. Uh, okay, so now we will just further explore some of the. So there is a, like, what will be the symptoms in the cardiovascular system? High cardiac output, hyperdynamic circulation is a subject, is an objective thing. Patient will what will be telling with reference to cardiac system. There may be signs, symptoms of heart failure, palpitation, chest pain, a cause of coronary artery disease. I think these will be there. So what else occur in cardiovascular system? Vasodilated state, hyperdynamic circulation, cirrhotic cardiomyopathy, drug-induced hypertension, portopulmonary hypertension. Okay, because it will have effect on the cardiovascular system. So now because why I am going in this way? We are just trying to correlate the symptoms with the pathology, and like what we are going to ask in the history. So we are correlating. Okay. So, okay. So, okay. So some words about hematological. Usually what happens that coagulation factors are produced in the liver. Okay. So when the liver will not be functioning nicely, so the coagulation factor, vitamin K dependent factors, and all factors actually they are produced in the liver, so they will be reduced. So it will result in coagulopathies. So then you should be knowing how will you identify like PTINR, APTT. What else you can do with reference to coagulation system? What will you do? There will be also thrombocytopenia. Am I right? So what will happen? More this one, not only the qualitative, quantitative, both qualitative and quantitative dysfunction will be occurring. Okay. Okay, so there will be anemia. There will be problems in the coagulation pathway. PT-INR will be deranged. Platelet count will be reduced. If you do CT-BT, that will also be increased. And then you can also have platelet dysfunction or known through this one platelet function assay. So bleeding time, clotting time, and platelet function assay. So this is how you will be identifying it. Clinically, there will be certain things which the hematological involvement will be through all the other factors as well, hematemesis, melena, okay, and upper GI bleed or lower GI bleed, which we have already some of points we have already discussed. Okay, so next point, what is hepatorenal syndrome?
The development
Yes.
of renal failure in a cirrhotic patient in which no other cause of renal failure is found.
Okay. So actually, if it's least likely that they will ask you in isolation hepatorenal syndrome, but if they ask, you should be knowing that there are two types. Hepatorenal syndrome are of two or three maybe, but I think you see what is the diagnostic criteria. They can few words about it, that chronic or acute liver disease with advanced hepatic failure and portal hypertension. This will be one thing. Low GFR as indicated by serum creatinine 133. This is actually 88. 88 is 1 milligram. Okay. So this is I think around 1.5. So 1.5 milligram per DL will be equivalent to 133 micromole per liter, or 24-hour creatinine clearance less than 40 mils. Absence of shock. Like there should not be any other reason of precipitation. No absence of shock, ongoing bacterial infection, and current or recent treatment with nephrotoxic drugs. Absence of GI fluid losses or renal fluid losses. Like you have to rule out any renal pathology, like anything which is damaging the kidneys directly. Okay. No sustained improvement in renal function following diuretic withdrawal and plasma expansions with 1.5 liter of isotonic. Like patient is not responding to fluid, patient is not responding to cessation of possible diuretics as well as any possible renal toxic medication. Okay, and proteinuria less than 500, and no ultrasonic evidence of obstructive uropathy or parenchymal renal disease. So to be very simple, you have to rule out, if you don't want to say that many words, or you don't want to remember each and everything, you can just say that there is no apparent cause of renal failure, direct renal failure. Okay, and a patient with history of this B Maggie, please don't write on the screen. Please don't write on the screen. Okay, so like then urine volume less than 5 mils, 500 mils, urinary sodium less than 10 milliequivalent, urine osmolality greater than plasma osmolality, and urine RBC less than 550 per HPF. And what is this HPF? I think this is microscopic finding. Anyways, so okay. So I think modified is this one. So cirrhosis with ascites, creatinine more than 1.5, absence of shock, absence of hypovolemia, no nephrotoxic drug. That's what I remember. Okay, so that's the thing which you should be. And two subtypes. One is very severe cirrhosis and rapidly progressive renal failure. Causes doubling of creatinine in less than 2 weeks. It may rise spontaneously or in association with treated SBP, and is usually accompanied by rapid deterioration of liver function. So this is severe one. And the other one, subacute. This type is characterized by stepwise deterioration of renal function over a longer time period. Actually, this is a very difficult diagnosis. I don't think so. It's very easy to diagnose. Okay, and but you should have just a somewhat idea what is it. And usual pathophysiology, how it happens, that splanchnic circulation of cirrhotic patients is dilated due to mediators, including nitric oxide. I know that you read from here. Okay, so there is increase of nitric oxide, but nitric oxide is not fully dependent on liver excretion. That's what I will be I'm sure. Okay, so these are different words. Nitric oxide is increased. That is something else. Okay, vasoactive peptide and glucagon, which are overproduced by the vascular endothelium, okay, in the splanchnic and portal circulation and not metabolized by the cirrhotic liver with portosystemic connections. This leads to a reduced systemic vascular resistance. This is interpreted in turn by J.G. Praetus of kidneys as effective hypovolemia, and the sympathetic nervous system and renin-angiotensin system is activated. Like there is reduced intravascular volume, leading to intense renal vasoconstriction. ADH is activated, giving rise to hyponatremia, and ascites associated with cirrhosis. In extreme instances, acute cortical necrosis due to renal artery vasoconstriction can occur. The cardiac output in HRS was traditionally felt to be high, but recent thinking puts cardiac dysfunction on back of cirrhosis as an important, this so-called cirrhotic cardiomyopathy. Like here they are saying cardiac output was traditionally felt to be high, but recent thinking puts cardiac function on background of cirrhosis as an important trigger of HRS. Like usually cardiac output will be more, but I think intravascular volume will be decreased. So that's is distinct from alcoholic and ischemic cardiomyopathy, both common in this patient group. Vasoconstriction is also observed to occur in cerebral arterial circulation. So the bottom line is that the mechanism is still exact mechanism will not be very clear, and there is sometimes there are so many things going on together, but usually what will happen that vasodilators not cleared because of portal obstruction and portal hypertension, so there will be more decrease in SVR, and JG apparatus they will cause as a result renin angiotensin system will be activated, and it will cause renal vasoconstriction. Okay, so so when ADH is also activated at the same time, so there will be more water absorption and it will lead to hyponatremia. Okay, so that's what will be leading to this HRS. Okay. Okay. So, you know how this hepatic encephalopathy occurs? One of the factor will be that ammonia is
bypass
metabolized.
due to portal hypertension.
Yes, so ammonia level will become increase. Am I right?
Yes, sir.
So any infection, GI bleeding, dehydration, constipation, electrolyte imbalance, like any medication which will be pushing the patient for it, it will lead to this hepatic encephalopathy. And there are traditional this flapping tremors, okay, which is called as asterixis or flapping tremors. So you will be what will you be doing if hepatic encephalopathy occur? You will try to treat SBP. You will try to treat constipation. You will give lactulose. Your approach will be, of course, airway breathing circulation. You might need to intubate the patient. You will try to correct any correctable things. You will try to push the child pox score. Am I right, Bilal? Sorry, Abdurrahman.
Yes, sir.
So hepatic encephalopathy, reversible syndrome. That so there will be a number of things like ammonia, okay, accumulation of ammonia, which is normally this metabolized. So it will be there. Supportive treatment, airway protection, okay, and lactulose. What else we discuss? Antibiotic. This gastrointestinal antibiotics also being given, and neomycin, I think given, I think if I'm not wrong. Okay, so if it is not, maybe liver transplant is also one of the factor. Okay, so how ascites develop? If I remember,
Due to increase water retention due to activation of renin angiotensin system and
this will be one thing.
low albumin level.
Low albumin level will leak the capillaries. Make the patient, make the capillaries leaky. So this is one thing. So hypoalbuminemia, portal hypertension, okay, and water retention. If someone asks you, three things are coming together. So actually, side by side, everything is going on. There are risk factors for renal problem. There are risk factors for renin-angiotensin. So hypovolemia, hypervolemia, hyponatremia, and it will be true hyponatremia or pseudo hyponatremia,
Dilution
dilutional
will be dilution.
or pseudo. Okay. So that's and then for some more things you see, like cirrhotic ascites is transudative. I always forget, but you should be knowing the difference between transudative and exudative. I don't remember. Uh, can anyone know? Do anyone know about it? What is difference between transudative and exudative? You know about it?
Sir, itna little do I know
Yes.
कि exudative contains is infective and contains it's
Your voice is gone. Please again. Anyways, I leave it. You should be knowing.
Sir, basically, transudative is due to hydrostatic pressure disbalance. It is a
Very good.
purely fluid. And whereas the exudative is basically inflammatory process, anything, it could be malignancy, infection, or something like that.
Infection. Very good. So this is the most simplest of, and actually the same thing will be there in the pleural effusion as well. Okay. So you should be knowing difference between transudative and exudative. So that's a very best thing you have told. The transudative usually is hydrostatic and that is infective. So that is and there is more difference between the proteins and everything you can have. Then another thing, when these patients, the medication which the liver patients are taking, one of them is spironolactone because of high RAS level. So there is hypokalemia. So there is water retention, but there is loss of potassium as well. That's why they use spironolactone. Okay. So this is a potassium sparing diuretic. So they give together with furosemide or separately. And another thing is that they do this paracentesis or removal, and whenever they are removing it, they have to replace with the volume, because otherwise it will, because when they remove, after some time again there will be accumulation. So intravascular volume will further deteriorate. So whenever they are trying to replace with albumin. That's what they do. Am I right?
Yes, sir.
So because now we will come to the common things. Inshallah, we have covered a number of atypical things, and we are coming uh, towards this child pug score, because in child pug score, all these things which we have discussed will come. And our aim is that if the patient is C, push to B. If the patient is B, push to A. If the patient is in A, don't let it in B. If patient is in B, don't let it go to the C. So that's what we are doing. And because as this ABC grows, there is high increase in mortality. That's what happens. Okay. So that's what happened. Though few words about this SBP, spontaneous bacterial peritonitis, which can occur. And there is like what is spontaneous bacterial peritonitis? Why it occurs?
So due to translocation of gut bacteria and dilution of uh, our immune system
Yes.
in
So they
initial stage.
Yes. So actually, the immunity will be decreased. So that's one of the reason. And then so SBP, and then the patient can go in the sepsis as well. Okay. So patient are more prone to develop sepsis. So with sepsis, all the sepsis bundle you might need to tell. So you should have an idea what you will be telling with reference to sepsis. Just a second. Portal hypertension. So portal hypertension, how it develops?
Sir, due to fibrous due to structural damage liver
Okay.
due to fibrous tissue scarring and nodular regeneration. There is increased resistance to blood flow in hepatic sinusitis.
Yes. So ultimately, it will result in portal hypertension. Okay. So whenever there is portal hypertension, the common sites of shunting, one is esophagus, rectum, anywhere else? Yes, Abdurrahman.
Sorry, respiratory system.
Yes.
Sir, is esophagus around the umbilicus, caput medusae, around the rectus, and there is some post, uh, like you can say liver, something like that.
Okay. So like usually these are questions which will be coming one by one. So actually there will be they will not ask only one thing. So be confident even if they are asking you in the liver in the liver long case, even in table viva they will not be asking that much detail. These questions are for liver long case. Okay. So remember when I'm trying to tell you in both ways. In the table viva, I will tell you only they will be asking any decompensation. You will risk stratify with reference of this Child-Pugh score, and you will try to treat the reversible thing. You will try to treat the ascites. You will try to replace albumin. You will try to give FFPs or correct the coagulation. Okay. If hepatic encephalopathy is there, or you will prevent it. So you will give lactulose. You will do this thing. If pleural effusion is there, you can have pleural tap. So that's what if they will you will be giving some spironolactone, furosemide. If cardiac failure is occurring, so you are giving inotropic support. This is very simple management, which is covering everything. Okay. And for portal hypertension, what medications are there? Beta blocker. One of them is beta blocker, and one of them is this octreotide, vasopressin. Okay. So they are not only control the bleeding, and they also they are reducing the portal pressures. So that's what you will be telling. Okay. Mm, so the same thing which we are discussing with reference to ascites, this is a very important step in our anesthesia management, that especially if you are doing a patient with ascites for an abdominal surgery, remember one thing: as soon as they open the abdomen, patient can sudden collapse. So reduce the level of anesthesia. Be ready for this fluid shift. You might need to have some baseline vasopressor support to counteract this thing. Okay. Because this thing, when you are dealing, so you will be knowing. So similarly, we will go to the anesthesia management shortly. So we are just trying to cover what are the pathology, what will be their sign symptoms. Okay. Usually portal hypertension patient will have the patient does not know that I have portal hypertension. Patient will be presenting with bleed, either upper GI bleed or lower GI bleed. Okay. Or patient might have this as we mentioned, this caput medusae and all these stuff. Abdominal distension will be, and all other factors which are leading to this happening will be there. Okay. So if variceal hemorrhage occur, so let's discuss this topic as well, that if variceal hemorrhage occur, what will be your management?
Sir, my approach would be airway breathing circulation.
Very good.
I will assess patient according to. I will support airway if needed. I will attach oxygen. I will
Okay.
take large bore IV lines
Okay.
and then I will send samples for CBC, PT, APTT, urea electrolytes, and
PT,
I will
APTT is,
inform.
yes, one thing I'm just correcting few things you are telling rightly, but only add on. Instead of PT, PTT, say PT INR. Don't miss this word INR, because INR and APTT can be there, but PT, APTT, if you are saying PT, APTT, is always say INR. Okay. And one
Okay.
thing, and then always say the word immediate assess the volume status. Okay. Because you might need to activate the massive transfusion protocol, because upper GI bleed is one of, like we discussed about maternal hemorrhage, any intractable trauma, okay, sorry, intractable bleeding, ruptured aortic aneurysm, the hepatic injury. These are the thing in which you might need to activate the massive transfusion protocol. So when you are answering nicely. Just add on these few words. Okay. So airway, breathing, circulation. Immediately assess the level of
Volume status.
hemorrhage. Activate massive transfusion protocol if needed. Need of blood and blood products. Then some specialities you need to call. What will be that specialities?
Gastroenterologist
For
and
endoscopic treatment,
yes, sir.
then
And
ICU care,
yes, sir. ICU
then
intensivist
and
and
in the meantime you will start the medical management. So medical
yes,
management will be with octreotide. Okay. They can ask you one thing about it is that is actually uh, no, I have not seen it, but I'm sorry. Yes. So there is a tube which is called as Sangsticken Blackmore tube. So I think it's better to see the picture. I think there is a balloon. Its mechanism is like balloon tamponade. So you can say in the meantime you are arranging, you will try to start the medical management, and if you have experience, you can try for this thing. In the meantime, you will try to arrange the blood and blood products. You can do tag, you can do ABGs, you can send baseline labs. Always mention ABGs, okay? Because ABGs and point of care testing like this hemostatic tests and homeostatic test. So homeostatic means the homeostatic conditions will be told by ABGs, and hemostatic status will be told by this thromboelastography or autumn. Okay. And clinical parameters, like what will you be doing? Clinical parameters like urine output, level of hemorrhage. Then if you can take arterial line, you can attach with cardiac output monitoring. Okay. And these things will be in addition to standard 1 and standard 2 monitoring. You can say that in this scenario you can have cardiac output monitoring if possible. Okay. Would you try to have CVP?
sir, without labs,
It's not a,
I
like CVP is not a good tool now. Okay. Nowadays, because it will not give you a very good, you can do the fluid status, you can more accurately with the cardiac output monitor, number one. And number two, here there are chances of coagulopathy, so there may be chances of further bleeding. Am I right? So unless the patient is stabilized, there is no need for this one. So also I did not mention about vitamin K. You can start vitamin K, you can start octreotide, you can have cardiac, of course, another thing, important thing is prevention of bacterial, not only peritonitis, also encephalopathy. So you will be giving antibiotics, you will be giving the lactulose or things like that to prevent encephalopathy. Okay. So we have covered this topic as well. So this was, I was saying, balloon tamponade using Sangstecken Blackmore tube. Okay. Useful in providing up to 24 hours of bridging therapy prior to more definitive treatment. Now, of course, because now nobody use it, because now everywhere it is available. And then another surgical treatment is transjugular intrahepatic portosystemic shunt, not surgical, it's actually interventional radiology who does it. So in radiologically guided insertion of a shunt between inferior vena cava and portal vein, so that they shunt, and thus effective decompression of portal venous system. So TIPS insertion should be considered in patients with uncontrolled or recurrent variceal bleeding. Recent data also suggests that early tips within 72 hours may improve mortality in patients with a high risk of rebleeding. In the exam, you can just say airway breathing circulation, control of correction of hemodynamics, correction of any coagulation or bleeding. Sank's taken Blackmore tube, immediately consult the endoscopy team, okay? And you can consider about because this will be not your decision to do the tips. So you can have a multidisciplinary team with ICU, with the gastroenterologist, and they might consider interventional radiologist. They might consider to have this procedure of tip, because in hemodynamically unstable patient, tips procedure cannot be done. This will be done after initial management. Am I right?
Yes, sir.
Okay. So we discussed about variceal portal hypertension, sepsis, SBP, ascites, hepatic encephalopathy, and hepatorenal syndrome. Okay, so there are some problems with reference to like hepatic. We will go further back and we will see what we have missed. Just a second, please. Functions of liver. We have discussed a number of things. We will just try to have few more words. Just a second, please. Okay, so what will be the functions of liver, Abdurrahman?
So the liver is involved in metabolism, in production of coagulation factors, in albumin production, and
Proteins,
in
plasma
yes,
proteins, coagulation
yes,
system, storage system, metabolic system.
yes, sir, and drug and toxin metabolism and lymph production.
Okay, so so when liver is not functioning, with reference to vitamin D, I think one of the step of activation of vitamin D also pass through the liver. Am I right?
Yes, sir.
And same is true in the iron. I don't remember exactly what is role of liver in iron metabolism. Just you should metabolic function. You should be having a more detail, and then digestive function with reference to bile. Okay, so when the bile is not properly utilized, there will be problem in the digestion, as well as in jaundice. This changes of this stool and urine, they also come. Okay. Okay, now a few words about hepatocellular destruction. So when there is hepatocellular, there are few enzymes you should be knowing: ALT, AST, gamma, GT. Okay, and further, if there is obstruction also, there will be alkaline phosphatase as well. But gamma GT is more in the liver, this alcoholic hepatitis. Am I right?
Yes, sir.
And another thing, if the patient with, like, if for example, these ALT, AST will be raised in acute more than chronic, because when the liver cells are destroyed, from where the ALT, AST will come. Okay, so this is just like indication that there is hepatocellular damage. So later on, when liver architecture is disturbed by cirrhosis, actually ALT, AST becomes normal. So this is another important point we should be knowing, that ALT, AST will become normal in later on. Okay. Okay. So Abdurrahman, just if we just go in the anesthesia conduct step by step. So in the evaluation, of course, the history and occupational health hazard will be there. If the patient is hepatitis B, hepatitis C, or any other viral, so you have to do the occupational health care, the universal precautions and special care in any like lines and and anything like that. So this is one point. The other point will be that you will try to have the risk stratification with reference to child-pux score. Okay, and with the child-pux score, you will classify into CBA. I will just let's have a look on this child-pux score, and your aim is to uh, do any correctable things which can which can give improvement in the just Child-Pugh score. Okay, so this is one important thing. Then what else you are expecting? Yes. Okay. So there are so many different ways you can learn. I make it Mr. Bean. So BEAN. So B for bilirubin, E for encephalopathy, and double A. So one A for albumin and one A for ascites, and then nutrition or PT. So A mortality 2.5, 2 to 5, 10, and more than 50. So this is you should be knowing. So and then what else you expect? What about airway? What will be the airway challenges in patient with liver failure or liver disease?
The patient will be more prone to deoxygenation due to decreased FRC due to ascites. There will be increased aspiration rates.
Mhm.
And
So you have to consider as full stomach. Okay.
yes,
And and like if you go further, so induction, there will be changes in albumin. Just tell me one thing. Our anesthesia medications, they are more attached to albumin or globulin? Yes. Actually, you should be knowing what drugs are albumin bind and what drugs are globulin bind. By the way, A for albumin, A for acidic. Usually, acidic drugs are bound to albumin. Okay. So globulin level does not affect much. So actually, yes, theoretically, we say that free drugs are more in liver disease. So there will be more effect. So actually, there is also related to receptors because receptor sensitivity is increased. So because of this thing, sometimes patients are more prone to the central nervous effects of, for example, opioids or benzodiazepine or because like effective volume, circulatory volume is decreased and more volume of distribution. That's what occur. So you should be knowing what exactly is going on. Okay. So induction monitoring. So what extra monitoring other than standard one, standard two, you should tell in a patient with liver
the
disease?
urine output monitoring, intra-invasive arterial monitoring. Uh, and,
Cardiac output.
uh, yes, sir. And temperature monitoring.
Temperature monitoring is standard one. Standard two. Okay. Temperature monitoring is a standard two. So where would you like to, you would like to do a core body temperature through esophagus or rectum?
Sir, if patient has history of varices, then it should be
No.
avoided.
Yes, it should be avoided. You should even nasopharyngeal. Sometime it can cause. So you might go for skin temperature, or you might have through the external audit this tympanic membrane because like in the exam they are just taking you that you know about it or not. So you can say that it's not 100% contraindicated, but you should be doing with care because it can cause bleeding. Okay. Even airway, like patient with CLD can have some other procedure. So careful airway manipulation, careful IV cannulation, careful even if you are trying, if there is a compelling indication to take CVP or even arterial line, you have to be careful because not only because of occupational hazard, because of more tendency to bleeding. Okay. So these are the things which you should be thinking. So anzulisis, preoperative anzulisis will be a problem. Okay, now what muscle relaxants would you like to give?
Sir, cis atracurium or atracurium.
Is a better choice than
Then aminosteroids. Uh,
minosteroid, vicuronium, rocuronium, pancuronium. Okay, because actually they are atracurium is a better choice. Cis atracurium is a better choice because another reason with atracurium will be that already there is more vasodilatation. Okay, so atracurium theoretically can release histamine, so it can cause these problems. Similarly, say the same thing is with succinylcholine cause of prolonged because of pseudocholinesterase. So this is also a consideration you should be thinking that its effect can be prolonged. And of course, because there is a reduced excretion of rocuronium and reduce metabolism also. Okay. Which opioids you should be considering? Fentanyl and remifentanil is a better. Remifentanil is the best option. Okay. And fentanyl can also be given for shorter duration of time. Um, this okay. What else? Yes, regional anesthesia. Regional anesthesia is always a controversial thing to do. Okay, like spinal epidural, again, you can in the exam you can say that there is risk. So unless there is compelling indication in the exam, you can easily say that it's a risky thing. So I will try to avoid. Okay, like any superficial blocks where you can stop the bleeding may be considered. Okay, and like what about like if you want to give carefully if in abdominal surgery, you can think about tab block. Okay, so but still you should be saying that unless strongly indicated, or you should be very careful to give. And because the half-life of bupivacaine and lignocaine, both of them will be increased, so you might need to reduce the maintenance doses. Okay, so like in any surgery, inhalational among inhalational versus tiva, tiva is better. Like if you are using propofol infusion, is it a better option than inhalational, or you can give?
Sir, I think inhalational is better because
You just have to monitor the parameters. Halothane is not a good choice. All these actually inhalation agents needs to be metabolized. So the medications which has the least metabolism, you should try to prefer. So if you make it 1, 2, 3, what should be your first choice inhalational agent?
desflurane,
Number 2,
uh, iso,
very good. ISO has remember the word of 2. So 0.02 for desflurane, 0.2 for isoflurane, 2% for sevoflurane, and 20% for halothane. Okay, it's roughly like that. So the best option is desflurane, which has least metabolism. So that's the theory. It's not contraindicated. So like you can use it, but that you should try to use which has less chances of okay. Another important thing with reference to monitoring and point of care testing, I forgot to mention about glucose. Why there is chances of hypoglycemia in liver patients?
sir, because in cirrhosis, because liver is involved in glucose metabolism and glycogen storage, so in DCLD, patient is more prone to develop hypoglycemia.
Yes. So hypoglycemia is because of glycogen depletion. Okay. And normally the liver is responding in different ways. Um, so here you will even gluconeogenesis will be a problematic thing. Okay. So esophageal Doppler fluid administration. They have written pulmonary artery occlusion pressure, but I don't think so. There is any compelling indication for this thing unless there is a portopulmonary hypertension or things like that. Okay. What else? Large bore rapid infuser system. Yes, among the reversal, you see, that's what I was telling you. Desflurane is probably the ideal volatile agent. Okay. So, okay. What about reversal? So, neostigmine metabolism is slowed, delayed in liver failure. Sugammadex is a safer option because it's inert. Okay. So, what else you need to think? Anything else in the anesthesia conduct I have missed? Please do let me know. We talked about preoperative evaluation, cardiac, pulmonary, hematological, Child-Pugh score, and then we think about anxiolysis, we think about yes, pre-medication with for acid prophylaxis. So this is, I think I missed. So ranitidine or PPI. PPI, ranitidine is better or PPI? I think ranitidine is better because PPI can lead to some like bacterial overgrowth or something like that, if I'm not wrong. Am I correct?
Yes, sir.
Okay. So then we think about induction. Yes, among the induction agent, if the patient is hemodynamically unstable, then you can consider about ketamine or etomidate. Otherwise, you can use titrated doses of propofol. Modified rapid sequence induction will be better. Rapid sequence induction is indicated, but again, because of free drug availability and there may be cardiovascular instability. So it's better to have arterial blood pressure monitoring. Yes, analgesia, among the analgesia, paracetamol, is it totally contraindicated or you can use with low doses?
Sir, we can use with low dose.
Because, paracetamol, remember, just tell me one thing. Does paracetamol cause actual liver damage in normal doses or no? Yes or no?
No,
How
sir.
paracetamol toxicity occurs? We will just have a look at it as well. What is the mechanism of paracetamol toxicity?
Sir, in toxic doses, पैरासीटामोल का जो सर ब्रेकडाउन हो रहा होता है नेपकिन
So NAPKI is the one which is toxic, and normally the liver is able to handle with it. Okay. So when NAPKI is overwhelmed, sorry, liver is overwhelmed by the NAPKI. So the NAPKI will be doing the damage. That's the usually it does not cause anything if liver is functioning nicely and NAPKI is dealt with. If NAPKI is not dealt with, then the problem occurs. Okay. So that's what is occurring. Okay.
Sir, what would be our post of analgesia management if we
Post
have to avoid NSAID and uh, blocks?
actually remifentanil or fentanyl PCA, because that is the safest option. Local infiltration, wound infiltration you can do. So actually it's a tricky risk, where you can say that it's a tricky thing to do. Like post-operative analgesia is, again, that's a challenging thing.
We can say that we should observe key patients in HDU and use low dose paracetamol and PCA fentanyl.
Yes. That's a safer answer, because you say that it's a risky thing. Patient, you cannot give regional anesthesia safely because of risk of bleeding. Okay. And the drugs which are metabolized by the liver, they are creating problem. NSAIDs can exacerbate the problems related to bleeding. So that's also something which you need to be careful. So there is no single word answer. You will make an individualized plan, taking in care all the conditions, the surgery. You will try to have minimum invasive procedures if it is deemed necessary. So yeah, whenever you are answering in this way, your answer will look smart. Okay. Analgesia. Fentanyl bolus of 10 microgram, not milligram. 10 mics. And anyways, we will just come out of this. Okay. So up till now, I have tried to cover a number of things related to liver. We will just dig into some things which we have not covered yet. Just a second, please. Okay, so what are the causes of chronic liver? Just need the article. Yes, this. Just a second, please. I'm trying to find the causes. Okay, so common etiologies of liver disease: alcoholic, hepatitis B, C, non-alcoholic fatty liver disease, and then hemochromatosis with the iron, and Wilson's disease with the copper. Alpha 1 antitrypsin deficiency, some autoimmune causes like autoimmune hepatitis, primary biliary cirrhosis, because this question they will be asking what is the etiology of chronic liver disease, and then they can ask you about this MELD and PELD and this, because this MELD and actually PELD is with reference to liver transplant. So this is something specific for liver transplant. But usually the better answer will be with reference to this one, childpox. So
Childbirth.
childpox, yes, childpox. And then you can say about the separately, like cardiac, you can say you will evaluate the cardiac system, cardiac risk factors, and you will stratify. If cardiac failure is there, you will stratify cardiac failure according to New York Heart Association. And then you should be chalking out the pulmonary risk factors. Okay, so pulmonary risk factors are there. You can say that I have to, in this patient, we have to chalk out pulmonary risk factors, renal risk factors, PONV risk factors, they're challenging analgesia plans. So if you know Abdurrahman, I hope you understand, because it's very simple if you understand. Wajiha, are you with us? Yes, Wajiha, are you here? I think Wajiha is not here. Anyways, so let's have a look on the I'm trying to figure out in a different way what are the possible causes of acute liver failure. Acute liver failure. What are etiologies?
So drug-induced infection and
A and E, hepatitis, idiosyncratic drug reactions, uh, paracetamol. Paracetamol, where is paracetamol? They have not written here paracetamol. Paracetamol overdose. Okay. So, and then other than we have already discussed everything about encephalopathy, what will be the sequelae, what will be the management with reference to yes, another thing which will come with reference to encephalopathy is ICP, because maybe you need to maintain the cerebral perfusion pressures with reference to encephalopathy. Okay, so and then you will try to treat. This is, you see, King's College, you will either go for symptomatic treatment, okay, and then you will have you should be knowing at least the parameter with reference to this King's College criteria for or this MELD PELD. Okay, I don't remember the parameter, but you should be knowing uh, what paracetamol toxicity, arterial pH less than 7.3, and all three of the following: PT more than 100 seconds, creatinine more than 300, and grade 3 encephalopathy. And in non paracetamol, pH, sorry, PT more than 100, and any three of them: unfavorable etiology, seronegative or drug associated fulminant hepatic failure, jaundice, more than 7 days before encephalopathy, age less than 10 or more than 40, and prothrombin time more than 50 seconds. I don't know how. So if this happens, the patient will be indicated for liver transplant. Okay. So, okay. So you will be taking care of the blood airway, breathing, circulation, care of like electrolytes, blood sugar, and maybe you need to have vasopressors. You might need to have arterial blood pressure monitoring. Okay. And you will try to have enteral feed as early as possible. If any other complication occur, you will dealt with accordingly. Okay. You might need to use furosemide, this potassium sparing diuretics. Okay. Mhm. Okay. This file I have discussed, I think. So these are the clinical signs, symptoms we have discussed. Okay. In history, uh, surgical history, beta blocker, examination. We discuss almost everything: anemia, jaundice, clubbing, chylomicronemia, muscle wasting, palmar erythema. Gynecomastia is also because of estrogen. Okay. And encephalopathy, testicular atrophy, splenomegaly, peripheral edema. This can all occur in patients with liver failure. Mm, Intraoperative management we have discussed. Pre-medication, careful analgesics. Anything you have written? Remifentanil, morphine should be avoided. Any medication with active metabolites you have to take care. Mm, We have discussed about it. So let's just recap and any other thing which you want to ask. These are the functions which we have already discussed. Okay.
Sir, anesthesia for liver transplant or
You
liver
know, actually,
resection.
I saw the liver resection is something else. Liver transplant is something else. This is totally different. Because in liver transplant, you will have all the things which we have discussed. Plus, remember, there will be either it is living related or cadaveric. So this is one thing. If you are just telling the all the things which we have discussed, this is part of liver transplant. Now you just have to think about there are 2 3 phases which you have to consider. One is dissection phase. Okay. So in dissection phase, if coagulopathy is not corrected, there will be more and more bleeding. This is one point. Then when they do the clamp, and there will be an hepatic phase. So in an hepatic phase, actually, and another important point with reference to this dissection phase, you don't give too much fluid, because if you give too much fluid, there is engorgement. Okay. And there will be more bleeding. So in a dissection phase, you don't give fluids. Then comes the anhepatic phase. So in anhepatic phase, that you have the time to correct everything. Okay. If there is any fluid problems, you have to correct. Electrolytes, you have to correct. If there is any hypocalcemia or this acidosis is there, you have to maintain a baseline vasopressors, because now everything is in your hands for some time. And when they do the perfusion, if you don't correct the deficits before, patient will suddenly collapse, because when they open, there is sudden gush of all the debris. And this anhepatic phase, when there is no liver, practically no liver at all, so that will lead to the vasodilator surge. Patient can suddenly collapse. So there are different ways to control it, because I have done a lot of liver transplant. So I'm telling you that there are so many different ways. You will correct the calcium, you will correct the acidosis, you will correct the fluid status, you will slightly increase the vasopressors. And at that time, there are different options. Either you increase a little bit of norepinephrine, when they are reperfusing. Okay. Or you can have attached with you epinephrine in a very diluted form, maybe 1 to 2 mics per ml. Okay. And you can give slowly boluses. Different, I have seen different people doing in different ways. So things will be in your hand, so you can handle. So this is the second step. And then after that, after this initial, as soon as liver starts picking up, it will take some time, the things will get better, and you will follow with lactate levels. Usually lactate levels will start coming down as soon as its liver starts functioning. Things will come in a better way. Then another important thing is that you have to monitor the coagulation status with rotum or tag, but you don't overcorrect. Okay. Because if you overcorrect, there will be chances of thrombosis. If you don't know these words which I have told, this is more than enough for liver transplant. I don't think so they will be asking you more than that. When Dr. Fazal were discussing, people dig into controversial things. Okay. Remember one thing, if you say that you will try to avoid epidural in patients with liver failure, nobody will fail you. Okay. You can say that, okay, we have to do risk versus benefit. If initially patient condition is not very bad, coagulation is corrected, you can place the catheter and then you can use it, and you will carefully remove the catheter. But still there will be chances of complications. There will be chances of epidural hematoma. There will be chances of infection, which is there because this patient is a liver patient. And sometime acute rejection can occur. So if acute rejection occur, what will you do? So in the exam, they are not asking you to perform liver transplant. If you tell these things, risk versus benefit, there is risk of bleeding, risk of infection versus analgesia because it's a big incision. So there is pain. Pain will also create a problem. So you will answer like this. Okay. So you can have some relatively less dangerous blocks, like you can tell about erector spiny block. You can tell about this one tab block. Okay. So of course, risk of bleeding will be there, but a single shot under ultrasound or a block in which you can control the bleeding or in which there are less chances of bleeding, QL block or erector spiny block or tab block is not 100% safe. But you just have to identify the difference. Identify the risk versus benefit. I hope, Abdur Rahman, you are okay.
Yes, sir.
So actually, in your exam, because this is a specialized subject, hepatitis A leading to acute liver failure. I don't know what was the comment. Anyways, so other drugs which and inhalational agents we have discussed, opioids we have discussed because this is active metabolite, and their metabolism will be slowed. Paracetamol overdosage. Yes. So we can have few words about it. We have already discussed because paracetamol poisoning, they can ask you as a complication separately as well. Actually, this word was not touching my mind. So it's glutathione. So glutathione stores are depleted. And actually, when they give this N-acetylcysteine, actually, it actually increases the glutathione stores. Okay. So normal pathways for metabolism are saturated and hepatic glutathione stores are exhausted. What is the message? Treatment of hepatitis A. It's symptomatic. There is nothing specific you can do. Is there any specific treatment of hepatitis A?
No, sir.
There is no specific treatment of hepatitis A. Even in some hepatitis, there is a use of antivirals or interferons, but I don't think so hepatitis A has any treatment. Okay. If it is causing fulminant hepatic failure, you have to do a liver transplant. Okay. So anyways, so there is a normogram which I never understood what it is, but actually, can anyone explain this normogram? I'm sorry, I have never understood this. Plasma paracetamol concentration going up, plasma paracetamol concentration, milligram per liter plasma. I think, with passage of time, if it is still high, so that's what I think they are they are saying? This is actually this was a topic which I don't never read in too much detail. When the plasma is on or above a single treatment line joining 100 milligram per liter at 4 hours. Okay. So they are saying like this. So if it is 100 at 4 hours, that's what I think they are trying to say. So that time you have to administer or 15 milligram per liter at 15 hours. Okay. So 15 comes here at 15 hours. So I think these 2 points they are saying that you have to. Okay, I understand. Maybe I will be. You see, there are 2 points. They are saying that if it is within 4 hours, the level in the plasma paracetamol level is still 100 milligram per liter. This is where you should be starting, and up to 15 hours. If it is there up to even 15, you have to continue. Okay, sorry, continue or you can give treatment. If it is going beyond these, then you are it's not indicated. Okay, understand? I repeat, if within 4 hours, if it is between this line, that if it is 100 milligram per liter at 4 hours, and it is going down, and even up to 15 hours, it's still it's more than 15. Okay, so you can still give an acetylcysteine. If it is crossing, then you don't need to give. Okay, and they can ask you what is the safe dose. So uh, not exceeding children, infant weighing less than 10 kg should not 7 more than 10 kg. What is the exact dose? I think more than 4 gram per day.
No, sir, more than 7 gram for adult.
More than 7 gram. And pediatric, what will be the dose? You see, that's what is written here. 60 milligram per kg. So I think it's 4 gram, my dear. Because usually, 70 kg we take. So it's more than 4 gram. I remember. Should not be more than 4 gram. The safe dose is not more than 4 gram. Just reconfirm it. Anyone can reconfirm, please let me know. Okay. Because in my concept, it should not be more than 4 gram. The safe dose is not more than 4 gram. Okay. Just reconfirm, please. Okay, so any questions, anything more you want to discuss, please?
Sir, what should be our answer to the question, what are your anesthetic goals? Should we answer it like we would risk pre-optimize and risk stratify the patient, and our goal would be to avoid perio, liver injury, and other end organ damage?
Yes. Like, any goals, whatever, like, whatever deal can be done. Like, when you want to even deal any business, what you do, you try to have some discount. Okay. So here the discount is in the form of any optimization. Okay. And then whatever you can sell, you will sell carefully. So same here, that you will try anything which is causing further damage. You will the main problems with reference to metabolism, airway, and then drug this like further bleeding. Okay, and further deterioration of the clinical condition. So you will just try to avoid these things. So these are your goals. And whatever is needed to perform these goals, you can tell. ascites drain, pleural effusion drain, avoidance of sedative pre-medications, acid prophylaxis, okay, rapid sequence, modified rapid sequence or rapid sequence induction, avoidance of medication which have liver metabolism. Am I right?
Yes, sir.
Do you know do read about physiology, pharmacological changes, okay, and I think we have covered almost. You should know about enzyme inducers and enzyme inhibitors. So inducers are these things like rifampicin, phenytoin. Chronic abuse is an inducer, and then thiopentone, phenobarbital. These are uh, all inducers. And inhibitors, metronidazole, isoniazid, chloramphenicol, cimetidine. So amiodarone. So these are, that's why grapefruit juice we advise in patient with liver disease. Okay. Did you see the question which I sent? Some of the physiological things, maybe we can have a look. Just a second, please. So, they can ask you about this portal triad with the portal vein, hepatic artery, and bile canaliculi. And you see, this is the better area of 1, 2, and 3 is more ischemic area. Okay, they can ask you about this zone. Okay, zone 1 is periportal zone where the blood supply is the highest. This zone is susceptible to damage by blood-borne toxins and infections. Zone 2 intermediate, and this is closer to the central vein, this area, but gets the least blood. Okay, so blood-borne infections or blood-borne problems will be in zone 1, and ischemic zone will be this one, zone 3. Then they can ask you about how much is the liver blood flow. There are two different sort, hepatic artery and portal vein. More is there with portal vein, but because there is less this oxygen content, so it is carrying about 50-50. That's what I remember here. They have written 40 to 50 and 50 to 60. But actually, it is around 50-50, but more blood coming from portal vein. Okay. And what else they can ask you? How the liver blood flow. Actually, these questions they are asking more in this Western exams. In our exams, they are least likely to be asked. They don't ask that much details. Okay. So anything else? Any one of you want to discuss anything, or if I have missed anything, please feel free. Yes, Sundas, you did not say anything. Waqar is also silent.
No, sir, thank you. It was very good lecture.
So it was not a lecture. It was not a
So
lecture.
it was
Don't.
a discussion. Yes,
It
yes, I
was
know.
it was a friendly discussion. Okay, it's
Yes,
a
sir.
friendly discussion because
Mm.
remember one thing: if you will make the studies your enemy, they will hurt you because in the if you are studying with tension, what just tell me one thing: what advantage will you get?
Mm.
Can you like for example, the people whom I show them the articles, they, oh my God, sir, so many articles. How can we read all of them? Just tell me one thing. Do even any examiner knows everything written in all the articles? No. Okay.
No.
Can you grab everything written in the article? No. You just have to, this is the way, like I was studying with you actually. Okay. So
Yes,
this is the
yes,
way
sir.
you should be dealing with the studies. You
Sir,
cannot understand.
only problem what we faced in our exam in Viva was presentation. We lacked
Yes.
good presentation.
Yes. So how you can
We
do?
know
How you can
everything
correct it?
by practicing.
Practicing. Okay. So just tell me one thing. Reading or cramming your holy book of anesthesia, the holy manhus, what I say, holy manhus Morgan Sharif. Just tell me one thing. whatever we have discussed. Can you cover with Morgan?
No.
Okay, so we have covered in now, because I know when I started, I was going with you in a very distracted way. I was going here and there. Now just recap. You will start with a simple history. You will get any abdominal pain or nausea, vomiting, or malaise and things, anything related to. Now you will thinking about the storage function and coagulation function and metabolic function and these are things. Now you can recap. Okay, anything which is any questions which are related to the etiology of liver disease. So maybe it is tattoos or injections or dental procedures. This will be coming into one thing. So now you are making a concept. Okay, these questions, then you will go further dig in. Okay, then you will go into each and every system, cardiovascular system, either failure, hyperdynamic circulation, ischemic heart disease, kidney, maybe renal failure, metabolic, electrolytes problem. Now I have, in 1 hour we have discussed everything, but in a friendly way. I have not make
Okay,
a
sir.
very horrible picture of this. So it's the same thing you have to tell. Think logically, and again, because this I show to all of you this approach. How to approach. Any patient come, evaluation on the basis of history, examination, and investigation. Easy.
Yes, sir. Yes,
Risk
sir.
assessment and stratification. Assessment and stratification means what is the risk and where you fall. Is it mild risk, intermediate risk, or high risk? Then, whatever the risk is, how to optimize medical condition. Any condition optimization, you can make a list of optimization: correction of anemia, correction of SITs, correction of pulmonary edema, correction of heart failure, correction of bronchospasm, correction of anything, smoking. Okay, incentive spirometry, you name anything you want, you can correct. Think. Then anticipation of complications. You have a prediction of rain, you have to take umbrella with you. Okay, so this is what is called anticipation of complications. And then you are a bloody anesthetist, you just have to think about your bloody things. How to give the tube, how to pass the IV cannula, how to do the monitoring, how to give the fluid, how to maintain the blood pressure, how to give the analgesia, how to wake the patient. Same bring in your picture. PONV. Doctor, patient is vomiting. This is when you are leaving the hospital, this is the thing which you will be damaging. Doctor, patient is not waking up. You have to take care of this sedation. Doctor, patient is not breathing well. You have to take care of the muscle relaxant. Doctor, patient is fighting delirium. You have to think about delirium. The common complication, the bleeding things are related to the surgeon normally. Okay, unless you do a block. Okay,
Yes.
so if you do a
Yes.
block, doctor, patient is dead. You have given some toxic dose. Okay, so these are the things. These are very simple things. Just tell me one thing. What's difficult? If you remember this word, just and practice this, and like instead of reading again, because I have so much love for your darling. I'm sorry, I hurt your feelings by, because in the group so many people become angry. Sir, how can you use so bad words about a book? I hate and I want to ban this bloody book out of anesthesia practice. So, because you
Sir,
cannot
why do
understand,
you hate that book so much?
because I am being tortured, I'm being abused, I'm being harassed, I'm sorry, I'm being raped by that book. So, just tell me
So
what should I
we are
say?
we are
What should
facing
I
the
say
same
about it?
situation.
I am an innocent person. I was an innocent person. I was damaged mentally by that bloody book because I failed many times, Alhamdulillah. And when I divorced it 4 times, now you see I am a fly free bird. Now I enjoy. I am enjoying my life. Okay. So that's what I want you to out of this torture. So this is a humble request. Now you fit this chart, okay, this chart in any disease, and then you will enjoy. Main category, liver, there are so many categories here. But if you are dealing with acute liver failure or chronic liver failure, just will be the main category. What is the pathology? You can think about the pathology. Mechanism of problems. Why the problem is occurring here? Because liver is the boss, the the army of body. Okay, nothing can be done without the army. So here same thing is occurring. Okay, so So you have to think now every system will be there. Diagnosis of the disease, evaluation of the system. Now you will be looking at all the systems. Here, problem with the airway, problem with the cardiac system, problem with the respiratory system, liver, kidneys, bone also, even bone marrow also. Homeostatic condition, acid-base problems are there. Electrolytes problems are there. Fluid problems are there. Now, again, cardiac risk, pulmonary risk, renal risk, aspiration risk, PONV risk, airway management, special monitoring needed, blood transfusion needed, blood and blood products. Just tell me one thing. If you format this thing in your what we have discussed since from where, just tell me one thing. Anything you miss or anything we miss? Pre-medication, monitoring, induction agent, muscle relaxants, maintenance, analgesia, fluid therapy, recovery, and where the hell you will send the patient after the surgery. That's what we do. Okay.
Yes,
But
sir.
usually what happens? You are stuck, sir. We will do pre-op care, intra-op care, and post-op care. And because this is like a spiritual ritual. Please don't overdo this thing. If you some things you can tell in pre-op, it's always better. In pre-op, you will arrange the ICU, or you will finish the surgery and then suddenly you will say, "Oh, I need ICU." Or you will arrange in pre-op. So majority of the things you have to do in intraoperative or post-operative, you can say in the pre-operative period. I have this patient, I have to do this invasive monitoring, I have to do this special care, I need to have blood warming devices, I want to have rapid infuser system, I want to have cell saver, I might need to have blood and blood products, I might need post-operative ICU, I might need special monitoring, whatever you need. You can tell in pre-operative. What's the problem? If you tell this, they will not fail you. Okay. And then the third thing will be with reference to surgery. What is the surgical urgency? What is the surgical risk? Any bleeding risk? Any special patient position? Usual duration? Where is the incision? Level of anesthesia required? Maybe, maybe in some procedures they are very simple, but they have high risk for bleeding. Like, for example, interventional radiology. They can suddenly bleed. Okay. Similarly, there are so many things which are incision drainage. Incision drainage looks very simple, but it can create, if you happen to cut a artery, what will you do? So things like that. Okay. So this is what all anesthesia is. If you read from wherever you are want, even your darling Morgan, if you bring the answers of all the diseases, okay, I can guarantee you will never fail. I can bet on it. Whenever you are answering, instead of try to recalling the words from the book, try to just answer these common. You can edit. This is not a last word. I have typed from my mind. Okay, I may be wrong. So you can make your own formula in which you don't miss anything. Okay. And it's better to tell at the start. And actually, exam is like a fight. So if you want to win the fight, the first punch is the most important punch. So when you go, when the examiner asks you a question, punch him so hard with your answer that he became numb and mute. If you when you start your answer and you tell about the most important things in first 30 seconds to 1 minute, you are pass in that question. Believe me. After that, you will have margin. So whenever they are asking you a scenario-based question, go for three things. When will be the patient category? The second thing will be the disease. And third thing will be the surgery. You have to cover all these three things. If you cover, because failure patient, like, we can have a discussion, a patient with decompensated liver disease is coming for emergency laboratory. What will be your anesthetic consideration? They will be asking you this question. So you will be saying, now we have discussed this thing in 1 hour. You have to tell in 1 minute. Okay. So I have this patient. So I will stratify the risk, whatever, because now we don't have any time. I will just discuss with the surgeon how much time we have, and we will start optimizing the patient. At the same time, we will push the patient for the surgery. We will try to arrange, give albumin, take IV lines, arrange for blood and blood products. And because if they are opening the abdomen, if they are doing, so the drain, it will be drained suddenly, we'll have
Fluid
this
switch and fluid
hemodynamic response.
instantly.
Okay. And the rest of the things you can just say, which we have discussed about airway, breathing, maintenance, induction, monitoring, fluid, post-op ICU. Just tell me one thing. What's the problem? If you understand this format, that this is the format you have to answer in the exam. Okay. And another
Yes.
thing I tell always, make a 30-second answer for all disease. Okay, so because we have covered the more important things about number of top of liver. Just practice 30-second answer for sickle cell disease. Think, speak out.
Sickle cell disease, my consideration will be related to the hydration of the patient and so 1 minute. Hydration, oxygenation. I'll avoid any acidotic changes, and I'll give good analgesia. So basically, so यही है.
Okay, so now think about it. That all these things what you are telling you, I can finish in one word. Sickle cell disease is anemia.
Sick-
Anemia. And
Anemia, yes.
according to the baseline hemoglobin S levels and
Yes.
of course hemoglobin level, we will be handling the situation. If it is an elective procedure, the hemoglobin S levels should be less than 30%.
Less than
Okay,
30%, yes.
this is one thing. And now the rest of the answer, whatever you were telling in coming, only one thing. You will try to avoid all the factors which can cause sickling.
Sickling, yes.
Okay.
Okay.
Then you
Yes.
can tell whatever you were telling, but you did not use the correct word to start with. Okay.
Anemia, yes.
Anemia. Anemia, it's an anemia. Like if I want to describe you, I can tell you 100 things about you, but I will say you are a woman. This is your first representation that you are a woman. Then we can that you are Sundas and you are a doctor and you are an anesthetist and you are in Pakistan and you are in Lahore and whatever. You are tall or like you see, same theory is coming in any disease. So, like it's anemia because of hemoglobinopathy. If you go further, anemia because of hemoglobinopathy, resulting in hemoglobin which is weak and tends to sickle. And when it's sickle, it can cause four different types of crisis: vaso-occlusive,
Yes,
aplastic,
vaso-occlusive, aplastic,
sequestrational,
hemolytic.
and hemolytic. Okay. And
Yes.
then
Yes.
further, you can elaborate your answer that now we have challenges with the all the sequelae of anemia, all the sequelae of multiple blood transfusion, all the sequelae of any crisis or any
Okay.
baseline infarcts in that patient. Okay, the patient, because of infarcts also, the another challenge you have is pain. The patient might
Yes.
maybe opioid addict, or maybe opioid, sorry,
Yes.
not opioid addict, opioid dependent patient maybe. So
Okay.
it will be a very challenging situation in that way. So okay, whatever you have read in sickle cell disease, this is the what you say kushta and summary of what you have read. Everything comes
Okay.
into it. Make this in your all cases. Myasthenia
Okay.
gravis, it's a neuromuscular problem because of destruction
Caused
of
by this.
postsynaptic acetylcholine receptors, leading to muscle weakness, and it is associated with other autoimmune disease. Now the patient is maybe taking anticholinesterase, steroids, and other autoimmune disease may be there. Now we are common anesthetic medication which we use has serious problems or interaction with the myasthenia gravis. Okay. So, and the patient will have bulbar weakness. Patient can have respiratory muscle weakness. So you have to make sure the patient does not have significant decrease in vital capacity or significant history of aspiration, because this patient, sorry, regurg, because that patient will be at risk of aspiration. Okay. So you
Yes,
have to
sir.
give a steroid replacement, stress dose steroid, and you have to anticipate for the complication of the immunosuppressant medication patient is taking. In I don't think so. 1 minute is finished. You prep you, and I am 100% sure, because in this way it's not written in the books, but still you have time. Daily make summary, what you say, kushta of all the diseases. Daily make
Okay, sir.
asthma, COPD, in which you open all the whatever is written and try to compose. Asthma, COPD, they are obstructive airway diseases,
Airway
reactive
disease, yes.
obstructive airway diseases. Difference between asthma and COPD is one is reversible and one is
Irreversible.
irreversible.
Irreversible,
Okay,
yes.
COPD may be presented as bronchitis or Emphysema.
Emphysema.
In bronchitis, there are more secretions and more cough. Okay,
More.
history of smoking, and
Yes.
in emphysema there is
Blue blotters
destruction.
and pink puffers.
Yes. So what is the result? The result is the patient is not able to maintain the oxygenation, and
Mm.
in all COPDs there is a reversible component. So you will try to target reversible component by giving bronchodilators, by giving antibiotics, by giving steroids, by doing incentive spirometry. If there is any heart failure, you try to treat the heart failure. If there is any pleural effusion, you need to tap it. In this answer, you can cover everything. Okay. So make a list of all the diseases: thalassemia, sickle cell disease, anemia, COPD, asthma, TB. Make a list and just convert it in few, like 1 minute answer of diabetes, 1 minute answer of hypertension, 1 minute answer of valvular heart disease. Because in table viva, you don't have to tell a love story. You just have to say I love you. That's it. You don't have time to create a precursor. I'm sorry, whatever word are coming. I'm just making you understand. You don't have time to tell big stories. You just have to tell very concise words. Okay. And remember one thing, please, I don't have anything in my head. You are more intelligent than us, than your previous old ducks. If we pass, you can pass. Okay? So don't be afraid from the exam. Exam is not difficult at all. Nobody, they are not something your enemy. Yes, they will try to just evaluate you, but it doesn't mean that you should be afraid. If you will afraid, you will not be even able to perform what you can. Okay. So thank you very much for listening.
Thank you, sir. No
And
problem.
Waqar
Thank
did
you.
not speak anything. And so inshallah, Abdurrahman. Yes, Abdurrahman.
सर ये क्वेश्चन था कि what would be our special consideration if patient has pre of jaundice? Will it be to rule out the cause of the jaundice, whether it is obstructive or hemolytic?
Remember one thing. For any question like this, the first thing you do one thing. You will see the surgical urgency. Anything you have to discuss with the surgeon, or any surgery in which you don't have time, you have to do the risk stratification. Number one, what you will be doing, taking care if you have an emergency case. Emergency jaundice, what you will be, the patient can have fever, patient can have uh, chances of going in sepsis, patient can have pancreatitis, patient can have elevated liver enzymes. Okay. So you will be taking care of anything which will be increasing it. So that's what you will be doing. Then a patient with jaundice can have renal failure as well. Okay. Because of all the pathologies which are going together. So you just have to take care, maintain the perfusion of the abdomen with like both liver as well as kidneys. You will be just doing the liver risk stratification. And if there is jaundice, maybe it is some viral infection, so you have to do the occupational health care. If you don't have time for optimization of anything, of course, if you have an elective case, of course, you will send the patient for evaluation. What is the level of jaundice? What is the etiology of jaundice? If there any acute problem like acute pancreatitis or hepatitis because of viral markers, hepatitis because of even the cholelithiasis, biliary, the stones are on morning walk to the biliary tree. They are also, they can cause a picture of jaundice. Am I right? So
Yes.
obstructive. So you just tell me one thing. I have just answered you with my previous knowledge. This is what I will not forget, and you will not forget. So whenever they are asking you a question, please think logically. Your logic. Just tell me one thing. Anything else? Anyone else want to add to what his question was? That if you have a patient with jaundice, what will you do? So first thing will be, you will be discussing with the surgeon what is the urgency of the surgery, how much time we have. Okay. Then further things will be coming into requirement. Okay.
Yes.
So acute jaundice, whatever we have discussed, you have to tell. Hypoglycemia will also be there. Airway problems will also be there, like things like that. So I hope this is an answer. Anyone wants to add to what I have answered to Abdul Rahman? Sayyid Muhammad Ali, you are silent.
No, no, sir, I am listening.
You are only listening. Or even I couldn't answer to your message.
Sir,
Okay.
regarding
So
jaundice, I
we
think
will discuss it after the
Sure,
class,
sure.
inshallah.
Yes, Safiullah, you are saying something?
sir, regarding jaundice, I think broadly we can say that the cause could be either medical or surgical. If urgency or emergency is needed, again we should discuss in detail. And
Very
if the
good.
medical, like acute liver failure, then we could take in consideration its coagulopathy, its bilirubin level, and its encephalopathy. Because
Yes.
in acute liver failure, we usually avoid elective surgery. We
Not
have to
Yuli.
consider this.
You will never do. We will
Yes, sir.
never do
Yeah,
elective surgery.
yes, sir. Yes, sir. Not usually. I mean, there is a time duration for that. I think for less than 26 weeks, it's contraindicated relatively till until
Again,
emergency.
Safiullah, sorry to interrupt you. You are using very
Yes, sir.
hard words. Contraindicated,
Okay.
26 weeks. Why are these are the things which will, you are killing yourself. This is my humble request. You don't need to tell these things. They will not give you extra salary for this thing. Why you are complicating yourself? Very simple. Acute, you don't have to do elective surgery. When the things are
No.
settled down, then again you will reconsider the things. That's it. Why you are telling the days and weeks? This is for cardiac and everything like that. For liver, I don't think so there is anything like that.
Okay, sir.
Understand, Safullah? Like you use
Yes,
the
sir. Yes.
word, in the exam, they are like your mother-in-law. They are not your enemy, but they will not let any of the blunder go down. Okay.
Yes, sir.
So my humble request, don't give verdicts like in by saying this 26 weeks, even till the time you are 100% sure that whatever you are saying is something very important, then say. Now think, go back and tell me that was this important to tell 26 weeks
Uh,
and was it important?
uh, no, sir.
Okay.
So,
So
elective surgery.
yes, elective surgery should be postponed. Emergency surgeries have to be proceeded with risk stratification. This is the two answers. And then in between discussion with the surgeon, how much, and then, for example, if there is emergency and the patient is not unstable, risk versus benefit.
Yes.
Discussion with the surgeon, discussion with the family, telling them the risk versus benefits, and then proceed. This word is there everywhere, whatever you are doing. Okay,
Yes.
agreed or no?
Yes, sir. Agreed.
Okay, so actually something which we are cardiac evaluation will be the same clinical history, and then because we did not say this today, we do a number of time chest X-ray, ECG, echo, thallium scan, exercise tolerance test, angiography. These are the things which are needed. Pulmonary function test with reference to pulmonary functions like incentive spirometry or the peak expiratory flow rate or this lung flow volume loops. These are the things which we are doing. Actually, this is a paper in which you can have a look, because whenever you are saying any investigation, they are say why you want to do CBC, why you want to do it, like you have to prove everything to see the hemoglobin level, to see the CBC, WBC count, to see the platelet count, to see the any picture of anemia. Okay, and then liver, if anything which can disturb the liver functions, either the hepatocellular damage or obstruction or synthetic function. Normally, what we are doing is these three things you can divide. Then renal function, anything which can disturb the renal function with reference to either dehydration or renal damage. Okay, and then further you can tell about everything. You can explain why you want to do this test, why you want to do this test. If you know, it becomes very easy. So make a list of all the investigation, so that whenever you use the word, you should know why and what change it will do to your management. This is another very important thing, that whatever you have done, what will be the, like, we are a number of time we are sending the patient for echo and we don't know what, I give you a scenario. A patient going for ERCP, okay, for this CBD stone. The patient has limited cardiac reserve. Would you send the patient for echo? What will you get from that echo? Can you delay the case of CBD stone? The patient will have further deterioration of the clinical condition. Patient can develop pancreatitis. Patient can go in sepsis. Patient can have hemodynamic instability. Patient will die. Okay. So in this case, you will just see that, okay, we are not able to identify the cardiac status, but in this case, you cannot delay the surgery. So you will do risk versus benefit. And in this, there are more risk of delaying the surgery for echo. So we will just do the risk stratification. We can have cardiologists on board. We can have invasive monitoring with arterial line, and we will proceed. Okay. We can have arrangement of vasopressors or inotropes or even pacemaker or any facility which we can have in emergency. We'll try to have cardiologists on board for all these things, and we will proceed. That should be the smart answer. Okay. So I think, thank you very much, all of you, for your time, and I hope you get some benefit. And thank you, Abdurrahman and Ali, and
Thank you, sir.
special our chief guest now. These Muhammad Kidan and Jennifer Rose, they are our chief guests. So thank you very much, and giving us honors. And any question which is left, please feel free to ask. I will try to tell whatever I know. I try to spend. And one request, please, all of you, don't forget this time of your life. Okay. Whenever I am talking to you, whenever what impulse, today is a weekend here. Okay. Why I am talking to you since last 2 hours? My wife has gone 2 times coming and staring at me, trying to stare at me when I did not look at her. Okay. Because you can understand why I am doing this. Because I don't forget, and I don't want to forget the pain which I had when I was stuck in my exam. Okay. So now this, I have made this my passion and my aim of my life. Okay. So my request to all of you, please don't forget this time of your life. And when you pass through, inshallah, you will pass through. Nobody will stuck here. After 6 months, you will be smiling at yourself. Okay. But please don't forget that someone else is waiting for your help. Whatever you can do for others, please do it. Because when we go from this world, only nice things which we do to others will remain in this world. Everything else we will leave in this world. Okay. So please try to be helpful to others. Your existence should not be a source of botheration for others. Your source should be your existence should be a source of help. So what you say, care for others. Okay. So thank you very much. And tomorrow, inshallah, let me think what we can do tomorrow. Because tomorrow is Sunday, maybe even, I have one of our friend who is in US. He was interested to have some class with you guys. He's an extraordinary person. Some of you know about him, Bilal Tufel. I will try to contact him if he is free. I will try to have a session with him. You will learn a lot of things from him. And please just try to go one by one. Anything, any topic which you don't know, please try to have few words about it. And that's the importance of these, having a bird eye view of all the articles. That maybe you open an article, you will just look into some charts, some key points, and it will help you. Okay. So inshallah, in coming days, I will try to cover as many topics as possible. So tomorrow, let me think. I will share what topic I want to discuss. Because I don't read anything right now. Whatever I am speaking from my mind. So pardon me if I do some mistake or if I miss something, because all of these things is extempore. And actually, maybe if I need to teach from a presentation or I'm very bad in it. Whatever I speak out extempore. So whenever I need to read from some source, I am very bad teacher. Okay. So thank you very much. Bye bye. See you tomorrow, inshallah.
Okay.